Greetings, everyone. My name is Amal Mattu, and I'm faculty here at University of Maryland, and welcome to our Crashing Patient Conference. For those of you that are interested in getting CME credit for the lectures that you're going to see, you can get CME credit on EMedHome. Check it out at www.EMedHome.com. And for those people that want live lectures, we're going to be right back here in October of 2013. Hope to see you then.
Good afternoon. Welcome again to the Crashing Patient course. What we're going to talk about over the course of the next 20 minutes is critical reading or critical care literature updates, the articles you've got to know. And quite honestly, we're only going to focus on one article, and that's not even available yet in print. So I'm going to bring you up to date with the latest and greatest on what's actually coming in the 2012 Surviving Sepsis Campaign Guidelines. Now, since this is a course on resuscitation as well as risk management, I want to lead off with this following case that I was asked to review by a law firm regarding a sepsis case. Now, this was a 58-year-old female brought into an emergency department from a local nursing home with a chief complaint of fever and hypotension. Paramedics radioed in as she was traveling in. As you can see, she's hypotensive, blood pressure of 60 over palp, little tachycardic as well as tachypnic. She had a past medical history as charted as hypertension, end-stage renal disease. She was on hemodialysis. She had a history of a CVA for which she had residual right-sided weakness, and then multiple episodes of pneumonia, most recently a few months ago for which she was hospitalized and then subsequently transferred to this nursing home. When she arrived in the emergency department, her first documented vital signs were these: a blood pressure of 60 over 40, a heart rate in the 120s. She was also tachypnic, febrile, as well as hypoxic on supplemental O2. On physical exam, she was only oriented to self as documented by the treating physician. The other documentation noted that she had coarse breath sounds bilaterally, overall tachycardic, the belly was soft, documented at no rebound or guarding, the residual right-sided weakness that was known from her previous CVA, a left upper extremity AV graft with a palpable thrill, but the patient did not come with any indwelling lines or Foley catheter. You can see a quick portable chest x-ray was shot and was confirming once again that she had recurrent pneumonia, multi-lobar pneumonia. So what happened to her over the ensuing 2 to 3 hours while she was in the emergency department? Unfortunately, it took at least an hour. It's hard to say based upon a review of the nursing notes, but it was at least an hour before the patient had IV access established. Once IV access was established, there was an initial order by the physician for 500 cc's of normal saline. The following order was for antibiotic, 2.25 grams of piperacillin tazobactam. Over the course of the next 90 minutes, labs returned. You can see labs were significant that she had acute kidney injury. We knew that she already had end-stage renal disease, but it seemed to be a little bit worse. She had only been receiving intermittent hemodialysis and was actually had improving kidney disease while she was at the nursing home. You could see that she had a lactate of 7.2 and her hemoglobin was a little over 10. Over the course now of yet another 2 hours, so we're now about 3 to 4 hours into her ED course, the total amount of fluid she received was about 1.5 liters. At that point, her MAP, her mean arterial pressure, was documented as 52 millimeters of mercury. The physician subsequently successfully placed an A-line, as well as a femoral central venous catheter, initiated dopamine for vasopressor support, and titrated the dopamine up to fairly high levels, but she continued to have a low mean arterial pressure along with persistent tachycardia. Another 60 to 65 minutes went by. She received 1 more liter of normal saline. Dopamine was maxed out as written on the chart. Phenylephrine was initiated, and she was admitted to the intensive care unit. At that point, when she got upstairs, both dopamine and phenylephrine were discontinued. The ICU physician initiated norepinephrine. Unfortunately, over the course of the next 6 to 7 hours while in the ICU, the patient developed recurrent or worsening hypotension. She was subsequently intubated, ventilated, but developed worsening hypoxia, and unfortunately, about 8 hours after her transfer from the emergency department, underwent a cardiac arrest for which she could not be resuscitated and upon autopsy, she was diagnosed as having an MRSA pneumonia, which subsequently took her life. Where the risk management comes into this is a claim was filed against the emergency physician. And during the deposition, during the claim, the attorney held up the 2008 Surviving Sepsis Campaign guidelines, pushed them across the table to the emergency physician, and asked if they were familiar with this document. After a little bit more conversation, what came to light, the attorney simply said, "Well, doctor, you did not follow international recommendations for the treatment of this patient clearly with septic shock. You failed to establish timely IV access. You failed to give an adequate volume challenge. You failed to administer not only timely antibiotics, but more importantly, broad-spectrum antibiotics for the etiology or the bug that finally took my patient's life. You did not measure a CVP to determine her volume status. You did not measure an SCVO2 to determine her overall tissue oxygenation. You failed to administer corticosteroids in a patient with vasopressor refractory shock. And as a result of all these things, your negligence resulted in this patient's demise." So with that, we're going to go into the updates, the 2012 Surviving Sepsis Campaign guidelines. What are the new updates that are coming, that are about to be published in January of 2013, and how do they impact us with respect to the resuscitation and care of ED patients with severe sepsis and septic shock? Perhaps one of the big take-home points that I like about the upcoming revisions is they state flat out in one of the first few pages that these recommendations, based upon the medical legal atmosphere, are developed intended to be best practice, but importantly, are not created with standard of care in mind, and that they certainly recognize that resource limitations may prevent many of us, depending on where we work, from accomplishing some of the recommendations. So with that, let's go through a few key modifications of QFE revisions and changes that are about to be out in print regarding these guidelines. Let's return to this patient. So this was a 58-year-old female brought from a nursing home for fever and hypotension. With respect to the initial resuscitation of patients with severe sepsis and septic shocks, the guidelines will continue to strongly recommend a protocolized quantitative resuscitation for patients who have sepsis-induced tissue hypoperfusion. They will continue to recommend the goal of obtaining a CVP of 8 to 12, a mean arterial pressure of above 65, a urine output of greater than 0.5 mLs per kilogram per hour, and an SCVO2 greater than or equal to 70%, or a mixed venous oxygen saturation greater than 65%. But let's drill down a little bit further and actually focus on CVP and SCVO2, since we need a central line to measure those two variables. And as I just said, the guidelines acknowledge that resource limitations may prevent many physicians from accomplishing these recommendations. Importantly, achieving a CVP of 8 to 12 or an SCVO2 greater than or equal to 70%, while desirable and recommended, these are not yet the standard of care. And I think that's important, and it applies to this particular case that we're reviewing. So when we go back to that protocolized quantitative resuscitation, if we have the capability, great, to measure CVP and SCVO2. But as I'll go through momentarily, especially with respect to SCVO2, the recommendations state certainly lactate can be used as a substitution if you don't have the availability or don't have the capability to measure an SCVO2. So that's with respect to the initial resuscitation. What about fluid choice? Do you want to use crystalloids? Do you want to use colloids? Do you want to use starches? And how do we monitor fluid resuscitation in our patients with severe sepsis? What are the guidelines going to recommend? Well, you can see here in our particular patient, once IV access was established, the order was written for 500 cc's of isotonic crystalloid, probably a little bit on the low side. The guidelines will strongly recommend that crystalloid be used as the initial fluid of choice, and that a minimum of 30 mLs per kilogram be administered over the first few hours. Now, certainly, some patients will require much more fluid resuscitation than that. They're simply saying a minimum of at least 30 cc's per kilogram of an isotonic crystalloid fluid. Well, is there anything else we can give with respect to fluid resuscitation? Based upon the Delaney meta-analysis looking at albumin, recall that this was published in Critical Care Medicine in 2011, they took a look at if fluid resuscitation was associated with a lower mortality. 17 studies, almost 2,000 patients, and in fact, the odds ratio was more favorable with respect to albumin administration. Now, having said that, a number of studies included in that meta-analysis had to be removed simply because the investigator is under investigation, or one of the primary authors for several of those studies is under ethical investigation. So if you take out all those studies, you're left with the several studies, or 9 studies, some of those in the pediatric population, and some using different concentrations of albumin, but nevertheless, the odds ratio was still favorable with respect to the use of albumin in patients with severe sepsis. So the guidelines will have a weak recommendation, but to consider adding albumin to the initial resuscitative fluid for patients with severe sepsis and septic shock. So how would you do that? One line, you're certainly going to continue to run in your crystalloids at least 30 mLs per kilogram, but concurrent with that, you can have a separate line with an infusion of albumin. Now, we don't know whether 5% is better, 20, 25% is better, but you can run it concurrently in at, say, 100 to 200 cc's per hour. What about starches for those of our international listeners? Certainly starches, we know that a higher molecular weight starch has been shown to be adversely effective in patients with severe sepsis or septic shock, so higher mortality. What about starches with lower molecular weight? Well, this study just came out a few months ago, New England Journal of Medicine, taking a look at Hess, 6% Hess, had a starch, with a lower molecular weight of 130 kilodaltons and a substitution factor of about 4, almost 800 patients, and it looked like those getting the starches did worse. In addition, there was, as we would expect, a higher incidence of renal dysfunction. Now, this is hot off the press just a few weeks ago, October, New England Journal of Medicine. A much bigger study by our Australian colleagues taking a look at the same solution, 6% Hess, with 130 molecular weight as well as a 0.4 substitution, 7,000 patients, and the result is there was no significant change in mortality. Now, I don't know where we're going to go with respect to the use of lower molecular weight starches, but certainly the recommendations will be strongly against using higher molecular weight starches in the fluid resuscitation of patients with severe sepsis and septic shock. And then the last thing that I think is fairly informative about the guidelines in terms of fluid resuscitation. You recall in the initial resuscitation, we're going to target our volume to a CVP of 8 to 12. Well, there's lots of literature that states that CVP really is not an adequate marker for not only fluid status, volume status, but also fluid or volume responsiveness. We know from lots of literature in the critical care world that dynamic markers of fluid resuscitation will be much better, or are much more beneficial than the use of CVP. The guidelines specifically reference pulse pressure variation, systolic pressure variation, but we know other things like ultrasound and as well as, say, passive leg raising can be used. So if you don't have that central line, in lieu of CVP, the guidelines, although an ungraded recommendation, are that we really should be using dynamic markers of fluid resuscitation. So with respect to fluids, strong recommendation for isotonic crystalloids, consider albumin, avoid high molecular weight starches, and then use dynamic markers of fluid resuscitation. What about antibiotics? So in this particular medical legal case, the physician wrote for 2.25 grams of piperacillin tazobactam. Probably not the best dose and certainly may not be broad spectrum. The guidelines will continue to strongly recommend that IV antibiotics be given within an hour for patients either with septic shock or with severe sepsis without shock. But importantly, much like CVP and SCVO2, antibiotic recommendation within an hour is desirable but not yet standard care. So we should be looking to get antibiotics on board as quickly as possible. They do clarify the issue of timing and blood cultures. So if blood cultures are going to take a reasonable degree of time, in other words, more than 45 minutes to obtain, give your IV antibiotics. Get the antibiotics on board early. If cultures work, great if you can get them quick, but don't delay the administration of antibiotics, especially if cultures were going to take some time to obtain. Now, importantly, the choice of antibiotics, I think everyone would be familiar. Certainly it's going to be dependent on the clinical presentation, the patient's previous history, known drug sensitivities and susceptibilities for your area, as well as any recent antibiotic use in that particular patient should be avoided. Importantly, the initial antibiotics should be broad spectrum, so the recommendations will say at least 2 classes or 2 antibiotics of different classes, and importantly, a full loading dose regardless of the initial renal function. So in this patient, looking back, probably could have written for a higher dose of piperacillin tazobactam, as well as expanded the coverage to include gram-positive. So broad spectrum, full loading dose, preferable within the first hour, but certainly as soon as possible. Now, what about pressors? So this particular patient, despite fluids, you could argue an inadequate amount of fluids, got started on a vasopressor. There have been 2 recent meta-analyses, and interesting looking at kind of the same data and coming to different conclusions. But more importantly, a study published within 2012, the DeBacker meta-analysis looking at norepinephrine and dopamine for patients in septic shock. Overall, over 1,400 patients, and as we know, dopamine was associated with more arrhythmias and a slight increased risk of death. So where the guidelines will come down is a strong recommendation that norepinephrine is the preferred initial vasopressor in the setting of septic shock. Interestingly, second-line agents are either epinephrine or vasopressin. So epinephrine can be given when an additional agent is needed, and an ungraded recommendation in terms of the use of vasopressin. So you have 2 selections or 2 choices for vasopressor use as a second-line agent. Dopamine and phenylephrine have kind of fallen by the wayside or way down in the upcoming 2012 guidelines. Really, dopamine, for all intents and purposes, is almost removed with the exception of select patients. So those that may have a low MAP in the setting of a low heart rate. So bradycardia and hypotension. Phenylephrine, they really advise against the use of phenylephrine because, as you know, it's a pure alpha, will increase afterload, and for those with substance-induced myocardial dysfunction, it could further impair cardiac output and delivery. Certainly, they will maintain phenylephrine in the guidelines as salvage therapy, but really relegated to 3rd line at best. What about the use of lactate? So we're all very familiar with the use of lactate, serial lactate values. In this patient, she started off with a lactate of 7.2, but it was never rechecked. We're all familiar with the Jones study, 2010, Journal of the American Medical Association, showing that lactate clearance was non-inferior to SCVO2. But I think all of us appreciate the limitations of that study in that very few patients actually got either an inotrope or blood transfusion based upon the lactate value or SCVO2. As a result, there's been a tremendous amount of debate back and forth as to what term to use for lactate. Do we use lactate clearance like the Jones investigators in the JAMA article and subsequent publications that have come out since, or do we use the term normalization? The guidelines will strongly say that you should target your resuscitation to the normalization of lactate. That's because I think all of us would agree, as an example, let's just say somebody started off with a lactate of 10, and we cleared it 10% to 9. Heading in the right direction, but by no means is a lactate of 9 sufficient. So we want to rapidly normalize or normalize lactate as soon as possible. Now, what about steroids? So the use of steroids in septic shock. The recommendations certainly are consistent in that if somebody is responding to fluids and maybe a single vasopressor on a stable dose, those patients don't benefit from steroids. Where you want to still think about corticosteroids is in the patient with fluid and vasopressor refractory shock. So as you're adding a second agent, start to think, could this be a patient that I need to give corticosteroids? There's a weak recommendation that hydrocortisone is the preferred. Vasopressor dexamethasone is out. 200 milligrams of hydrocortisone a day, and they'll recommend a weak recommendation, but to use a continuous infusion of hydrocortisone. And that's actually to prevent the peaks in glucose spiking with repeated bolus dosing. So hydrocortisone, 200 milligrams a day, administered via continuous infusion. Just a few quick supportive care measures, and then we'll wrap up with the important updates to the Surviving Sepsis campaign. Regarding glucose control, so you've performed the initial resuscitation, gotten antibiotics on board early, adequately fluid resuscitated them using dynamic markers of fluid resuscitation, maybe vasopressor use, and maybe steroid use. As the patient remains in the emergency department, think about glucose. The goal target for glucose is less than 180 milligrams per deciliter. If you've got two values above 180, provide insulin to bring it down, but there's really no range, just around 180 or slightly under. And then lastly, bicarbonate therapy. Lots of debate regarding bicarbonate therapy. Is it really useful? Well, we don't know because there's actually no studies that evaluate the use of bicarbonate actually on patient outcome. We certainly know for those that have sepsis-induced lactic acidosis, bicarbonate has not been shown to be beneficial, nor has it been shown, as we were once taught or told, to actually improve vasoregulatory response to catecholamines. So we were once taught, give bicarbonate because it'll make the tissues or vasculature more responsive to the catecholamines or vasopressors we're giving. Turns out we don't really have that evidence, and actually bicarbonate in the setting of sepsis-induced lactic acidosis may worsen the acidosis at the intracellular level. So with that, the key things regarding the 2012 sepsis updates that are coming. Once again, recommendations are intended to be best practice and not standard of care. And those resource limitations may prevent many of us from achieving some of these recommendations, but importantly, once again, not standard of care. In terms of the initial resuscitation, I certainly agree with a protocolized quantitative resuscitation. They will continue to maintain the early goal-directed therapy goals of a CVP of 8 to 12, MAP greater than or equal to 65, urine output greater than 0.5 cc's per kilogram per hour, and an SCVO2 greater than or equal to 70%. Having said that, they also make room for the use of lactate normalization in the setting where resources are limited and you cannot place a central line, nor if you don't want, or having said that, if you don't want to, you can use lactate normalization. Also regarding CVP and the many limitations of CVP on volume responsiveness, using dynamic markers. Once again, an ungraded recommendation, but the use of dynamic markers for fluid resuscitation. Antibiotics within an hour for those with severe sepsis or septic shock is desirable, but they do say not standard of care yet, but certainly desirable from a patient outcome. And remember, they need to be broad spectrum, 2 classes of antibiotics, a full loading dose, and given as soon as possible. Regarding fluids, crystalloids still strongly recommended as the initial agent. However, consider adding albumin concurrently with that crystalloid infusion, and then once again using dynamic markers for fluid resuscitation and avoiding high molecular weight starches. Regarding pressors, norepinephrine is the preferred initial agent. Epinephrine or vasopressin can be used as second line, but really dopamine and phenylephrine are almost out of the recommendations. Only in select patients should you consider using these third-line agents. In a patient with fluid and vasopressor refractory shock, still consider corticosteroids, and if you're going to give them, hydrocortisone, not dexamethasone, 200 milligrams per day, and a continuous infusion on the recommendations. In terms of glucose control, get it under 180 if 2 values are above that, but no need to press it down much farther than 180. And then really think twice about giving bicarbonate, despite the pH, because we know in sepsis-induced lactic acidosis, bicarbonate has not been shown to have any effect on outcome and may, in fact, worsen intracellular acidosis. So with that, we're going to wrap up the big literature update that's about to come out in print. Hopefully I've given you some pearls, not only from medical legally, but also, more importantly, patient care pearls on what's coming in the 2012 Surviving Sepsis Campaign guidelines. Thanks so much for your attention.